Good afternoon, everyone. We're going to kick off in a minute's time. Thank you for joining. We've got around 25 people signed up today, so thank you for those who've joined us. Okay, welcome to this webinar. I'm Andy Thomas, I'm Director at Physical. Now, I personally have been working with BTE for nearly 15 years, 9 years at Physical, so I'm really looking forward to this talk today. So we're joined today by Phill Heritage, who is a lecturer at the AECC University College. They've had the BTE Primus system there for about 10 years. And today Phil's going to be talking about the use of the BTE PrimusRS for neuromuscular control training in a specialist sporting context. So the Primus is widely used, about 50 of them in the UK currently. And Phil's going to be talking more about the athletic side of things. So Phill, thank you very much for joining us on your day off, I may add. Thank you for that. And
no
I will pass over to you.
Cheers, thank you. Yeah, thanks for tuning in, and apologies for having to postpone from last week. Had some other stuff going on that got in the way. So yeah, hopefully this will be of interest to a few of you. I've tried to pick an interesting case for it, but we're looking at how we use the controlled passive movement aspect or part of the Primus's capability for athletes in particular. So if I can just get this all going properly. Just managed to lose my controls. So it should be on about the speaker, is that right, Andy? Has it moved on? Yeah. So I am, as Andy said, I'm a lecturer at AECC University College. I qualified or trained as a sports scientist and specialised in physiology, but also have worked quite a bit in sports rehabilitation. And after university, I've worked privately. I then went and worked in professional football for a few years. I also have a background in rugby union here, and then have worked a lot with ultra endurance runners. I currently work with the British Paranordic ski team. And I'm about to start a PhD next month looking at a few things around movement and the effects of the kind of machinery they sit on during competition. I'm an accredited sport and exercise scientist with my speciality in physiology from the British Association of Sport and Exercise Sciences. And then I'm also a course lead at the institution, as well as running our Sport Performance Centre, which is an on-site laboratory where we run physiology, testing, psychology, analysis and testing as well, and a range of support for athletes, as well as biomechanical assessment, sports rehabilitation, and a few other bits and pieces. So we're quite busy. So the PrimusRS makes up one of the bits of equipment that we use. We also have the MCU from BTE as well, which we're about to start doing quite a big research project with as well, hopefully. But the Primus in particular has had extensive use with athletic populations with us, probably more than any other group. So we've used it extensively for isokinetic testing to look at hamstring and quad ratios. And as part of our partnership with AFC Bournemouth, or our past partnership with AFC Bournemouth, we used to do all their pre-season screening, lots of rehabilitation for them as well. But also we've tested it on, we work with national volleyball players. We've used it with sprinters, triple jumpers, and we've done some kind of new bits and pieces with amputee athletes as well, which I won't talk about today, but maybe can talk about in the future. As well as I will kind of make a brief reference to another skier we work with who had a subarachnoid brain bleed, and we've used CPM with him quite a bit for his retraining, essentially as kind of a post-stroke form of exercise management. So as part of our standard athlete assessment, we've got the piece of equipment, so we should use it. And in the bottom right, you can see with the graph and the data outputs, the information that our athletes would receive. And like I say, we're doing some experimentation with power athletes. So I was asked by Andy and Kate to pick out a case study, really, just to show you the kind of things we normally use CPM for, or the controlled passive movement capability for. And one of the things that we've observed over time is there seems to be a link between activation patterns, so both activation and deactivation, during mainly knee movements, because that's the main movement that we've assessed, and injury risk in athletes, and primarily in footballers, but we have seen the same thing with triple jumpers, long jumpers. So one of the focuses that we tend to have during rehabilitation and management is improving neuromuscular activation. And by doing that, we tend to see, especially for the hamstrings, it seems to be protective against the kind of overbearing forces of the quadriceps. So especially in people, we see too commonly really over-dominant quadriceps, and by working on the activation patterns within the hamstrings, it seems to be quite an effective way of improving force generation as well, and just that resistance to the agonist movement of the quadriceps. And that seems to have an injury prevention impact. So we can clearly identify areas that need improvement by using controlled passive movement, and also by assessing the outcomes of assessments. And I'll just show you, this is a case study from a professional footballer who was playing in the championship at the time, and he'd undergone an ACL reconstruction on his right leg. So this was at the beginning of, or started at the beginning of the return to play phase. So he'd already undergone surgery and his intensive rehabilitation, a combination of abroad and at home. And then would start to come in and see us every couple of days, sort of maybe every 2 or 3 days, to have some intensive but quite light rehabilitation using the Primus, and then it got ramped up a little bit. So some of the issues included his strength symmetry, consistency as well in his activation. So getting a quick activation, a nice straight, consistent level of activation, and then deactivation. So with CPM, what we're able to do is set specific goals, and it's a really nice function on the machine because of the it gives you biofeedback, a really nice form of biofeedback. So you have a line on the graph. As they activate, the line moves and heads towards a target line, which is dotted. There's a beep which will tell you if they've gone over or under, so they get lots of feedback to tell them how their activation is and whether it's where you intend for it to be, and you're able to adjust the target load down to just a single Newton, maybe even less than Newton. We don't go that small in terms of increments. And then you can have this kind of consistent increase in load over time. And we tend to work at around 10 repetitions per set of exercises. And depending on the level of fatigue, we'll look at doing 2 to 3 sets of activation. So the data that I've included is from their most fatigued activation patterns on each visit to our lab to have their rehab. In terms of some of the principles, what we wanted to do, and what we do whenever we work on ACL reconstructions, so minimize the time to the target force, and therefore speed up or accelerate that activation. And especially when you look at the point at which hamstring injuries tend to happen most, which is at that turn from concentric to eccentric and vice versa. We want to get that activation and deactivation patterning as quick as possible so that we can protect the hamstring as much as possible. So minimizing that time to the target force, and then maximizing the time they spend at the target force as well, so we can maximize output, maximize resistance to the agonist muscle, and then minimize the relaxation time. So if we think in terms of a footballer, you've got a high velocity, high force concentric contraction coming from the quadriceps, which is the agonist during a kicking movement, and then a high velocity, high force eccentric contraction from the antagonist. And often it's this imbalance which is the issue. So by improving the activation patterns, we can maximize the force production out of the hamstring muscle. And then on the other side, we're just looking at isometric stabilization. Interestingly, though, it tends to be this other side which is injured more often than not in footballers or soccer players when they do damage their ACLs, PCLs. So here's just the data for the player in his pre-season screening, and you can see that activation is very poor. So he has this gradual increase in force production or force output from the hamstring. This is an eccentric load. So again, because of the type of movement or what the hamstring is going to be used for during their sport, it's going to be under eccentric load or at the greatest risk under eccentric load most often. So we focus a lot on eccentric testing and eccentric exercise. So under eccentric loading, we can see this very slow activation pattern and actually only reaching a peak towards the end of pretty much all of the repetitions that they've done. So peak force 568 newtons. Time within about 10% of that peak force is only 4%. So they're not able to maintain that peak for very long. So that's another kind of area for us to try and improve. And then with the CPM function, so hamstrings working eccentrically and then quadriceps working concentrically. So again, you have to have that patterning of movement between where you're concentrating on the activation of the quadriceps whilst also working the hamstrings eccentrically, and we can focus on them in isolation rather than with both movements happening at once. We use 60 degrees per second, and then for the first month, whose data I haven't included, we increased the force from only about 105 to 145 newtons. So this started about 5 months after the test data that you saw on the last slide, which was up in the high 400s. So compared to when he's healthy, we're looking at around a quarter of strength, but the priority is to get optimal activation, but also we don't want to be working at high loads because of the danger with the shearing stress within the knee using this type of movement. So the following is training every sort of 2 to 4 days. It all depends on availability. And then the last 3 sessions are separated by a week each, and you'll see that the load drops to kind of come into line with the increase in load in their training away from the lab. So as they start to do more return to play training and more team training, you see that the visits start to become less frequent, but also the loads become lower because fatigue is a much bigger issue. And you'll see what I think is an impact of the training load that they were under on their activation patterns in those last 3. So you can see here the dotted line is the target force, and we can see a nice quick activation, and then maintenance is quite good along. And this, as I say, is in either the second or third set of exercises, target of 155 newtons there. So we can get these really nice clear activation patterns, and the athlete's seeing the same sort of thing while they're doing the exercise, so they can track in real time the forces that they're generating from that hamstring. And then we just increase by 5 newtons on each visit. So every 2 to 3 days, maybe 4 days, we get a 5 Newton increase in the forces we're looking for them to generate. You can see as we get to 185, maybe the activation patterns are getting a little bit wayward. However, one of the issues with the demands of this is was a core figure in the team. So the medical team's priority was to get them back on the pitch, which is often kind of one of the unfortunate things you'll get with sort of elite athletic populations, is getting them back on the pitch before maybe they're completely fit enough. So we do start to see maybe a bit of a slight struggle really in keeping that activation pattern. But then it massively improved on the next visit, and still a 5 Newton increase in force. And now we're getting up towards about 50% of their healthy activation forces or testing forces. So here at 200 Newtons, we can see activation has started to suffer. On the quadriceps in the hamstrings, really nice clean activation pattern, relatively good maintenance as well at that force, and then quick drop off at the end. And then we start coming into these last 3 before they return to competitive play, and we bring the forces back down again, focusing again on the quality of activation, down to 170, back up to 180 Newtons, and just looking at the hamstring on that last session. We don't know how successful it is until, number 1, we know whether or not they have another ACL injury, number 2, whether they have a hamstring injury, and number 3, until we've compared their post-rehab testing to their pre-rehab testing. Now, obviously, we don't have any test data here because we didn't want to do maximal testing on someone who just had an ACL reconstruction, maximal isokinetic testing. So the dotted line here is from his pre-season test, and you can see that very slow to activate, and the peak doesn't come until towards the end, and then when we look at post, we've got a much faster activation. It's still not ideal. This is maximal eccentric contraction. But the amount of time spent within 10% of the max is 30 rather than 4%. And the peak force is only, I think, around 21 newtons less than pre-season. So this is, the injury happened in the September. This is the following April. So we've managed to get the hamstring peak force almost where it was before injury, and within 7-8 months of full ACL rupture. So not a bad result, I think. And obviously the big thing is that there's other rehab going on away from our facility, but the quality of force production could potentially be, at least in part, put down to that improvement in activation patterning, improvement in neuromuscular control. And it's something that we need to do more work on, more research on, probably, to see what the impact is, and you know, how much of it's down to CPM over other training methods. Just in terms of some of the, or looking at the max strengths, we did have some data post-injury on eccentric hamstring strength, and we see a drop and then back up almost to that starting strength again. So as I say, we're only working at around 25% of peak forces, maybe working up towards less than 50%, but still getting, I think, fairly, I'm loath to use the word significant as a researcher, but it looks like we get fairly high impact in terms of the effect of using CPM rather than just isokinetic, you know, 80% eccentric loading like we would do to strengthen the muscle normally. By focusing on the neuromuscular control, improving that activation patterning of the fibers, we're actually seeing improvement in fiber recruitment within the muscle, which is potentially going to be what's improving eccentric or maintenance of eccentric forces over a whole movement. Some of the positives I just thought I'd put down in terms of using the Primus. So the really nice thing is how specific you can be in terms of the loads and ranges, and also actually being able to load under eccentric loading is really nice, especially when you're working with hamstrings. But also with, there's a few other areas that we've looked at as well. So it is really nice to have that option to work on eccentrics as well as concentrics, and to have that specificity. Visuals make target activation achievable, and so the biofeedback element of it is fantastic as well. And actually, if you have that system, and I have used other systems which don't have that element to them, so, you know, compared to describing to someone what it should feel like, or, you know, someone having to just feel through the machine's arm how much force they should or shouldn't be applying, to have that instant biofeedback in real time is a really effective tool. And then extremely flexible to your requirements. So the target force, as I said, but also the movement. So if ideally we would have used this earlier in the rehabilitation, and you obviously have the benefits of being able to restrict the ranges of motion that you're working in, the speeds that you're working at as well. As I say, we use 60 degrees, but we've also done other testing, which is looking at 120, 150, 180 on other joints as well. The work duration, so we can dictate how long they're working for, the speeds that they're working at. And in terms of for future rehabilitation, looking at eccentric into concentric versus just looking at those isolated movements would be quite nice to do. And then easy analysis of deactivation and activation efficiency. You can get all the data, put it onto Excel, and then have a play around with it to look at, you know, to calculate the data such as time to peaks, amount of time spent at certain forces or within certain ranges. So you can actually get quite a lot of good data to assess the impact of the treatment that you're giving. And hopefully that's been of use.
Thanks, Phil. No, that was really interesting. So before we go to the questions that have been asked, how did you establish that target force for the CPM?
To be honest, it's used on a kind of a case-by-case basis. So we have a look at, with this particular group, it's part of it's established through talking with the medical team. So we might look at, you know, selecting a percentage which we can then go up in kind of 5 Newton blocks, because they're having such frequent rehab, which is quite nice compared to using it on just a private client. where they might not be able to afford to come in and have testing or treatment done every 2 to 4 days. We get to have quite a lot of time with these people. So yeah, we didn't want to strain it too much. We'd rather go too low than too high to begin with. And really, I mean, we were starting at around 25% of their pre-season max, which you would expect them to be quite comfortable doing, especially since they'd already gone through the first few stages of rehabilitation within the club.
Okay, great. Also, I'd like to welcome Jeff Johnson, who is Clinical Application Specialist at BTE Technologies. He's currently in transit in Atlanta, so if he has to go at any point, then that's the reason why. Thanks for joining us, Jeff. So, question through here. So when did you introduce the CPM training, Phil?
Well, it's before my time. So, I mean, I've been at the institution this is my 7th year, I think. I think the Primus has been there maybe 12 or 13 years, I guess. Been there for quite a while. It's been used as long as I've been using it. So I don't know what the answer is in terms of the institution, but yeah, I've been aware of it since I've been aware of the Primus. And
with that particular patient subject group, when would you normally introduce that within the rehab process?
Ideally, because obviously we're a secondary provider, so we're an external provider to the club. Ideally, we'd use it almost straight away, even when they're in a restricted range of movement. As soon as they're able to move under force, I would use it as soon as possible, because you can use resistance bands, which you would be using with them anyway. It's going to kind of apply with the forces you're looking at. You can be much more targeted, and you're going to have the same amount of shearing stress going through the ACL. If you don't like, or if you want to avoid shearing stress specifically, then you're not going to use this type of movement. But I think ideally I'd use it as soon as they're able to really move the knee, because you can use it in such restricted ranges of movement.
Okay, Jeff, I'll bring you in on that as well. You've been using the Primus for a number of years. What's your experience of where CPM fits within the rehab process?
I think Phil's nailed it really well, that it can be instituted very early on, and it's not just pure passive motion where you put someone on a device and the machine moves them and you walk away, but they're activating early. They're trying to regain that motor control, and that's something that's lost so early on following an injury. So the sooner that you can reintroduce motor control, motor learning, the better off we find that all athletes, non-athletes, all age populations will do in their rehab. And Phil also made another great point that this type of muscle activation, it doesn't have to be maximal. So many times we hear that max, give your best, but in reality, if they learn motor control early, they can have a better outcome, because they know how to control force later on when they may not be fully able to return to function. They may not be fully ready for max, but they'll have a better sense of awareness of how much force that they're applying through range.
I mean, having tried this CPM with target force, it is quite a unique treatment option that you can do on there. How do you find that from a learning perspective? How does the subject engage with it?
I think it's kind of become a core part of our of the rehab. So by showing them what they need to be doing and explaining to them while they're doing it, they're getting an understanding of exactly how the muscle needs to be loaded. So it's not just about maximizing your peak force, but explaining to them, if you look at this player's pre-season, you can say, well, your peak force is good and it's better than it is at the end, but you're only achieving it at the end, and that's why you're getting injuries. But if we can improve the activation patterning, maximize your time within, an acceptable range of that maximum, you're getting the most out of that muscle, and you're going to protect your joint. And ultimately, players don't want to be suffering ACL ruptures very frequently. They don't want them at all. So if you can explain to them that by improving this patterning over just improving peaks, you're going to have an impact on longevity of career and things, because the muscle is going to activate better. You do get this sort of education element of the rehabilitation is there kind of quite naturally.
Okay, yeah, I was going to go to the first question then. So how would you do this if you didn't have a BTE Primus? Is there any other way of replicating this?
Yeah, so one of the other people that I've mentioned, he'd had the subarachnoid brain bleed. So with him, we can't get him in. He lives too far away. So we see him quite infrequently, really. But we send him away with resistance bands and explain to him how he needs to be doing the movements. You could do it with a weight stack. So if you wanted to be more specific, then you could attach them onto a cable with a weight machine. The difficulty is you're not going to get the timing on the movement, so the speed of movement. But again, there are ways of working on that. If they're going through 90 degrees and it's 60 degrees per second, then they've got a second and a half to go through, you know, a right angle movement. And you can give them that kind of direction if they're not able to get access to the machinery. So there are ways that we can work with it. And we've even gone to the extent of taking resistance bands in particular away with us onto camps. And then we get the athlete to train with it before they go and ski, get that pre-activation. Because with this guy in particular, when it takes him a little bit of time to build up those neuromuscular pathways. So his movement is very, very juddery, very jolty until he warms up. And it's almost like you have to warm up that communication pathway as well as warm up the muscle. So he has issues with activation and deactivation. So he struggles to activate, and once he activates, he struggles to deactivate. So by getting him to do the work just sat on a chair with a resistance band, we can achieve similar outcomes, just not with the specificity.
This is from one of our NHS users. So how would you use this in a post-orthopedic?
It depends on kind of what you're looking to achieve. So again, it's something that I would use quite early. It depends on quite a lot of things. So what movement you're looking at, which muscles, because that's going to have quite a big impact on things like load. But the beauty of it is it's such a dynamic piece of kit. So I mean, we've used it on, I used it last year on a tennis player who'd had a ligament rupture in their thumb, and we would do it using the pinch machines to do similar things. Yeah, so we used that quite early. We were using that within a week of him having the surgery, and his return to play was quite quick. His improvements were good. So yeah, it depends on quite a lot of factors.
Yeah, I'll see if I can clarify which where that was, which joint that was about. So did you do any work on the uninvolved side, or was it purely on the involved?
Yeah, so only the injured side. So, and that would be something that would be nice to do, because again, we tend to see quite a lot of asymmetry on between left to right, and and like I say, it tends to be that actually we spend a lot of time looking at hamstring quad strength ratios in the dominant leg, and this is a right foot player. But actually, we tend to see ACL injuries happen in the standing leg, but actually when you do see that, it tends to be because of factors other than anatomy. So things like the ground and a second player impacting them and things. But we don't do enough of it. And actually it's something that, again, if I was working within the squad, then, or within the medical team there, and you had time with them all day, every day, then I would be definitely doing bilateral training with them. Yeah. Because I expect if you looked at their left side, it's probably pretty atrocious in terms of, so his right leg's probably much better. And actually, yeah, there were further injuries. I won't say too much, otherwise people will know who it is, but there were further injuries, which would kind of tell you that that might be the case.
Yeah. And did you use EMG data?
No, so that's one of the things we haven't done, to be honest, and that I've looked at doing quite a bit, and I will be doing probably in the future, is syncing up between EMG and Primus data, because the Primus is indicative in terms of muscle activation, because it's using the outcome. So the assumption is you've achieved that outcome through improved activation. But yeah, it's something that I've been exploring for a few years, actually, us doing, and hopefully is on the horizon now.
Jeff, I don't know if Jeff's still there, but Jeff, is there anything that you can add in terms of, I know you've done some work on EMG integration with dynamometry? You're on mute, Jeff.
Not a whole lot, but EMG and data collection with Primus, they work really well together. You can certainly isolate glute, hamstring, quads, all of those during muscle activation. I did have a question for Phil regarding this, the types of athletes that you're seeing. So between a skier and a footballer, which one of those would you say needs more of the eccentric activation, or do they both need equal or close to equal?
Yeah, in terms of because I work only with amputee skier. I do work with one standing skier, but he's still a para skier. But it depends. So with the footballers, I think eccentrics on the hamstrings is a really key area. With our seated amputee skiers, we're looking at lateral flexion in particular, because it's around their agility on snow. I'm wondering, one of the things I'm kind of thinking aloud is how important lateral flexion and control and lateral flexion, peak forces and things is in agility. With our standing guy, we look at eccentrics because he has a real issue with eccentric activation and deactivation, like I was saying. So it kind of depends. If I was looking at an able-bodied cross-country skier, I would almost certainly be focusing more on the concentric movements. So and probably more around the shoulder and the hip rather than, and the hip's a difficult one really, but certainly around the shoulders. So anything which is leading to, and we did some actually double poling based movement on the Primus. So overhead pull downs and internal rotation actions, which we're also looking at with jiu-jitsu practitioners as well as shoulder internal rotation activation. But yeah, probably more concentrics with a able-bodied standing cross-country skier, and probably para standing cross-country skier, depending on the issue, and more concentrics on a sitter. Whereas, yeah, footballers or soccer players, we're looking at concentric quad, eccentric hamstring. Same with sprinters, I think.
Great. Does that answer your question, Jeff? Yeah, he's saying yes to that. Yeah, no, great. That's really good. Thank you very much for that, Phil. We'd love to hear about the other things as they develop, the projects that you're working on. It's really exciting working with those elite athletes. So we've seen the Primus is used extensively in those as a rehab tool as well as the assessment. So no, thank you very much for sharing your expertise and experience with that. And
Yes,
we'd love to have you back at some point.
Yeah, well, I'll collect some more data and then we can have a chat again. Yeah.
No, sounds good. Great. No, thank you very much for everyone for joining us. And thank you, Phil, for that. And if we don't see anyone before, then have a great Christmas.
Cheers. Thanks, Andy.
Cheers, guys. Thanks, Jeff. Cheers. Bye-bye.